This is Chicago's Morning Answer with Dan Proft and Amy Jacobson on AM 560. The Answer.
Good morning, Dan and Amy. 47,000 Americans died from opioid abuse in 2017. More than car accidents or at the hands of somebody using a weapon, using a gun in particular. Well more. So what to do about it, particularly in the era of increased legalization of controlled substances, not just marijuana, but as we were talking about during the break in Denver, now they're going to psychedelic mushrooms too.
Yeah, they've passed that. That's legal now.
Okay, the Amsterdam of the Rocky Mountains. We'll see where this goes. Maybe it'll go to opioids. And frankly, we have this problem. There's been a number of pretty interesting documentaries on the subject of prescription opioid abuse, and how much the medical profession has to be held to account for the ubiquity of prescriptions for opioids that get people hooked on those painkillers.
Did you see the movie Ben is Back? It's with Julie Roberts, and it's about addiction, and it's really good. And it addresses that, too, about how if your child breaks a bone, they put you on painkillers and opioids. It becomes a lifelong addiction.
Well, there's certainly a lot of examples of that, and it's a dramatization, but there's been a lot of documentaries that provide some of the hard science and the hard data on it, including the fact that Americans represent 5% of the world's population and consume 75% of the prescription drugs. Is that a good thing, the therapeutic state? Well, why don't we put that to an expert in the field. He is Dr. Ken Candido, Chicago anesthesia and pain specialist. Dr. Candido, thanks for joining us. Appreciate it.
Good morning, Dan. Good morning, Amy.
Morning.
Thanks for having me on your show. Always a privilege. Thank you.
Pleasure. So what about that? When you see those stats coming in terms of the abuse, the overdoses, the death, and of course you know what I just said about the incidence of prescription drugs, scripts that are written by doctors. What is going on with opioids that needs to change in America?
It's a great question. It's obviously an enormous social and legal problem, and it confronts and confounds our specialty, meaning not just pain management physicians, but physicians in general. And just by a little way of background, I should point out, the opioid epidemic, we spend a lot of time talking about it. It's on everyone's lips, and it's in the lay press, and it's, of course, something that physicians are very cognizant of. But we've had a history in this country dating back to the American Civil War of narcotics addiction. We had what was called soldier's disease, when we had morphine had been isolated in 1804 and the hollow syringe was made in 1853. And we had 400,000 Americans addicted to narcotics back in 1861 to 1865. Everyone thinks this is a new phenomenon. What's happened now in the last 30 or 40 years is that physicians basically got handcuffed into bringing narcotics into primary care practices. And in 1980 and 1986, we had a couple of articles which were carelessly written by physicians who were on the lam. They were taking large donations from the narcotics manufacturing industry, and they wrote scientific papers which claimed that patients who used narcotics for legitimate purposes rarely got addicted. And then JACO, the Joint Commission, basically came out with a primer which was actually published with the help of Purdue Pharma, the makers of OxyContin, that stated that physicians should be prescribing narcotics for benign pain because patients don't get addicted when they have legitimate pain conditions. And we got into this circuitous thinking that we should be using narcotics for anybody with any social ill, with any pain condition, with any medical condition where there was discomfort. You pointed out a great statistic, Dan. We have about 325 million Americans out of a world population of 7.2 billion. So we're 4.5% of the world's population, and we consume about 75 to 80% of all the narcotics in the world. Well, how do we get there? Because Americans have basically a sense of entitlement. Americans don't like to feel any discomfort or pain. And then we had the manufacturing and the pharmaceutical industry, which was basically breathing down our throats to tell us that patients should not be uncomfortable.
Let me just interrupt there, though. So you have pharma paying for Cook studies that say things that aren't true. But at some point, doctors have to know that these prescriptions are producing bad outcomes for their patients. And so doesn't that inform their behavior?
Absolutely, Dan. But if you look at how the pendulum has swung a few years back in California, especially, there were physicians who were being sent to prison for under-prescribing narcotics, and so these cases were sensationalized. There was case law of individuals who actually went to jail because patients and patients' families would actually sue them for medical negligence, claiming that their pain was undertreated and undermanaged. And then we got into this. Again, it's a circuitous path of dysfunctional thinking that patients should not be having pain. But really, and you pointed out a great statistic, we have about 70,000 overdose deaths in this country per year, 70,000 from all comers, all types of medications. And with narcotics, it's 47,600. That's the most recent statistics from the CDC, the Centers for Disease Control and Prevention. However, the most, I think, impressive number is that the actual incidence of overdoses from prescription opioids, people like myself and my colleagues who write narcotics with genuinely good intent, that's actually on the decline. Why we have an increase in the actual deaths is because of prescription deaths with other synthetic narcotics. I don't want to beat up on China. We've got this trade war going on, but the Chinese have been instrumental in creating a synthetic drug called fentanyl. Yeah. And this fentanyl is now permeating our borders both through Canada and Mexico and gaining access to Americans. And so the actual incidence, the increase, the rise in deaths from narcotics is not from prescriptions. I think that the medical community has read the message. We drank the Kool-Aid before, but now we're back on our good behavior. And we're starting to take patients to task. We're doing urine drug monitoring. We're signing opioid agreements with patients. We're scrutinizing what our patients are doing. But people continue to die at an alarming rate, as you pointed out, more than gun homicides and approaching motor vehicle accidents and so forth.
Yeah, they're saying about 130 people in the U.S. die every day from overdosing on opioids. But what is an alternative? Say if your loved one's going to have an operation, is there anything you could do besides writing a prescription for painkillers, pain relievers?
Absolutely. So the most important thing is to have an open and honest discussion, and this is what we're trying to educate our younger physicians about, is to give realistic expectations. I think that, and I use the term entitlement, I think people have an expectation that they're going to get in and have a hip or a knee replaced and they're going to just walk out and start dancing the same evening with no pain. And I think surgeons have had to change their mantra and turn this around and say, this is going to be a painful procedure, but we're going to manage your pain not with narcotics, but using what we call multimodal, several different modalities, different chemical classes of medications which work on various pathways, both in the peripheral and the central nervous system, to blunt your pain response. You're still going to be uncomfortable, but you're going to have to do work now. You're going to have to use local anesthetics. You're going to have to use drugs that block the brain, like gabapentin. You're going to have to use patches, creams, gels, and good old-fashioned Tylenol and medications that have anti-inflammatory properties. And so the pendulum has swung back now to us using this multimodality or multimodal thinking. And it's had an enormous impact on our patients.
Now, the flip side, too, I got an email from a friend of the difficulty in filling prescriptions. She recounts the story of her 86-year-old mother who's got rheumatoid arthritis in her spine and has had difficulty getting her prescription filled at the pharmacy, even when her doctor intervened with the pharmacist to try to facilitate it. What's going on there with potentially this incidence of difficulty getting prescriptions filled?
Well, that's a great point, Dan. And actually, the insurance companies and the pharmacies now, again, the pendulum has swung back towards less opioids and being minimalistic. And there's a certain level of collusion and oversight. We have in this state, we have the Illinois Prescription Drug Monitoring Program, and any physician who's a member who signs up can actually go on the website and punch in their patient's name and see who's writing prescriptions and what quantities and what dates they were filled. But the pharmacists now also, they don't want to have their licenses revoked. They're also on the lookout for the punitive actions of oversight agencies, the DEA, the FDA, and all the other people that are pointing fingers. This is kind of like with the Mueller report. Once Barr said we're going to investigate the investigators, the finger started pointing in every direction. So they pointed to physicians, they're pointing to pharmacists, they're pointing to the drug pharma manufacturers. Everybody's looking at everybody else and saying, you caused this problem. But I think the pharmacists are doing a magnificent job of trying to be minimalistic. Why should an 86-year-old person with a benign condition need oxycodone, 10 Percocet a day? I mean, it's ludicrous. And I think that they've done a good job, although there are some individuals who are overzealous, who are perhaps making decisions outside their specialty. I don't think that people should override a physician's judgment, but that's actually what we see happening in many regards.
Now, we had one of your colleagues in the medical community, Dr. Zeke Emanuel, on the show yesterday. We were talking
Yes.
about the competing Medicare for all plans, government takeover of health insurance, and by extension, health care. And he makes the argument that the way to improve quality and reduce cost is for a Medicare for all type program, the building upon Obamacare to mandate coverage and have essentially the government be the provider of health insurance of first resort. How do you respond to that? How has Obamacare impacted your profession in terms of Chicago anesthesiology pain specialist, your business, your group of doctors, and what do you think would happen under a Medicare for all plan as Zeke is proposing or Bernie is proposing?
Oh, Bernie. Well, so I'm respectful of individuals who are socialists, but I really disagree with their agenda, and I think that it's been that socialized medicine and Medicare for all, and the government actually intervening in being the third-party payer for all individuals across the country, has been a catastrophic failure if we look at other countries. I mean, there's a dirty little secret. You look at the Canadian healthcare system, any Canadian with money sneaks across the border to have their hip or their knee replaced because they don't want to wait 6 months or a year, the obligatory waiting time, while this healthcare is rationed or apportioned. But it's a step further because the socialization process also reduces reimbursements to physicians. Now, I wouldn't quarrel with you if you said, well, physicians are in the top 1 or 2% of nationwide of individuals who are reimbursed for their work and their services. But we continue to be sued by medical malpractice attorneys. We continue to have enormous overhead costs associated with our practices. In my own personal practice, we've seen a reduction of about 25 to 30% in the last 4 or 5 years as this socialization of medicine and adopting Obamacare principles has permeated into our practice. So we see the insurance companies now have taken a drastic stance about reducing reimbursement towards physicians. And again, no one's crying in their soup. The bus drivers and the school teachers and the janitorial staff are not saying, "Oh, you poor doctors, you're getting less money now. You'll have to drive a Mercedes-Benz instead of your Maserati or your Ferrari." But at the same time, we're seeing a drastic reduction in what we're being reimbursed for. And I submit to you that if you went to any other profession in this country, whether it's attorneys or teachers or firemen or policemen, and said, you're going to start working and doing the same amount of work every year but getting less and less remuneration for that, will there be a massive outcry?
Well, right,
populace.
but what about in terms of patient outcomes? Let's make this patient-centered. What has been done under Obamacare in the last decade and what is proposed under Medicare for All? What does that mean for patient outcomes?
Well, I think that on a positive note, they're looking at being proactive and preemptive. So now we're screening more individuals. We're trying to screen for diabetes, hemoglobin A1C. We're looking for individuals with possible markers for certain malignancies like prostate cancer. We're measuring and monitoring and treating blood pressure more efficiently and more effectively. But then at the same time, when Americans are gluttonous and we have horrible habits, horrible dietary habits, we don't exercise, we smoke too much, we drink too much. And until we change the culture and we can get individual patients to buy into the fact that they have to be responsible and accountable for their own conduct and their own behavior, we're not going to really change too much. So we can apportion healthcare, we can ration it, we can try to admonish individuals to behave themselves. But unless you adopt a system like the Japanese, who actually measure body mass index and waistline size for height and actually apportion care based upon individuals' habits, unless we adopt a system that has some metrics built into it to be punitive to patients themselves, we're not going to make much headway.
Whoa. Hey, measuring waist size.
Sir.
We're in an era where morbidly obese women are on the cover of the Sports Illustrated swimsuit era, doctor. Let's just hold the phone here. Dr. Ken Candido, Chicago anesthesiology pain specialist. Dr. Candido, thanks for joining us. Appreciate it.
My pleasure. Have a great day, folks.
You too.
Thank you so much.
Thank
care.
you. Yeah, and he joined us on our turnkey.pro answer line.
It's what Chicago is talking about. It's Chicago's Morning Answer with Dan and Amy on AM 560.